Welcome everyone. Thank you so much for joining our Southeast Chapter webinar that we have, our quarterly talk. Today I'm really excited to have our presenters join us. And as we start all of our meetings, we will always start with our Southeast Chapter mission and vision. So I'm Vivian Liao. I am the president-elect of the Southeast Chapter of SCCM, and today we are co-hosting this event with the Georgia Aspen with Ashley DePriest, who's our president, and she will talk more about Gaspin later on. But right now I just want to talk about our mission, which is what we start all of our meetings with, and the goal and the mission of the Southeast Chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. It is the vision of the chapter that all critically ill and injured persons in the Southeast region receive care from a present integrated team of dedicated, trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. Just a little bit more information about our chapter. So the Southeast Chapter of SCCM represents various states, including Alabama, Arkansas, Georgia, Kentucky, Louisiana, Mississippi, and Tennessee. So we're a multi-professional organization that composed of physicians, nurses, pharmacists, respiratory therapists, physician assistants, and other healthcare professionals. So the goal of the chapter is to encourage SCCM national membership, as well as to build the Southeast Chapter while providing education and networking opportunities to its members. This is a recent event that we had in October, just to highlight some of the activities. So we had a 5K race that was called Stomp Out Sepsis, held on October 4th, that was sponsored by various healthcare professionals, healthcare systems, and the proceeds of the event went to the Sepsis Alliance, and we were able to raise $2,500 from various members and members in the community to donate to the Sepsis Alliance. So we are so thankful to have Northside Hospital, Emory Healthcare sponsor our race, and we had, you see the photos with members and as well as members of the community to come together. So we were excited to have chapter presence as well as community presence. And you see one of our chapter leadership members was one of the top finishers, so congratulations. Other events for the chapter, we will be holding chapter elections for the 2026 and 2028 term. So if you're interested in learning the available positions as well as roles and responsibilities, please email us there at communications@sccmsc.org and be on the lookout for elections and the link to vote. So please stay tuned. Other announcements of the chapter, we have transitioned another social media platform. So we're now on Blue Sky. So if you're on Blue Sky, please follow us there. Here is our social media handle on Blue Sky, and we also included the QR code there. And as we're continuing to plan, we want the programming to be tailored to the needs of our chapter. So as we continue to identify educational sessions, we have a call for meeting topics as well as speakers. So if there are any topics that you want to hear more about, please contact us at communications@sccm.org for suggestions. And we're always open to hearing what topics that you want to learn more about. Other important updates, if you're not already following us, we are on X, we're on Facebook, we're also active on Instagram, as well as our YouTube page. So any of our educational sessions will be broadcasted and posted on our YouTube for later viewing. All right, I will turn it over to Ashley DePriest.
Thank you, Vivian, and I will kind of do a couple of quick introductions for Gaspin. Again, my name is Ashley DePriest. I am have the honor to serve as the president for Gaspin for the next 2 years. And I also serve on the board of directors for the Southeast chapter of SCCM, and would love to put in a little plug. I know officer elections are coming, and the pharmacists do an amazing job of running that group, but I would love to see some dietitians jump over and get involved with SCCM as well. It's a really fulfilling group to work with. So check that out for sure if you're a dietitian. But we would also love to have your membership if you're an SCCM member and perhaps maybe not an Aspen or Gaspin member. We'd love to have you join us, invest your career and invest in the future of your patients. We do a lot of education, a lot of outreach, and of course we have our annual conference each year that features top speakers in their fields of nutrition and nutrition support. So we'd love to have you join us. And then we are also on social media. You can find more about our social media pages as well as our happenings on our website, which is a QR code right there. And so without further ado, I will go ahead and introduce our esteemed speakers today. I'm super excited to have both of these guys joining us. I'm going to start with Dr. Keith Miller, who is a professor of surgery and trauma and critical care at the University of Louisville School of Medicine. His clinical expertise lies in care of the traumatically injured patient, emergency general surgery, surgical education, and surgical nutrition. His research contributions have focused on firearm injury epidemiology, firearm injury prevention, shock resuscitation, surgical nutrition, and critical care nutrition. So all things patients that really need a lot of nutrition. And so we're really excited to hear from him today. And of course, we also have Dr. Steve McClave. He's received his MD from the Ohio State University, completed internal medicine residency and chief residency at Medical University of South Carolina. He finished his gastroenterology fellowship at the University of South Florida in Tampa. He's a professor of medicine and director of clinical nutrition at the University of Louisville School of Medicine, where he has been on the faculty for the past 40 years. He was on the Aspen Board of Directors for 6 years and is a past president of the Aspen Society. He was a co-chairman and lead author of both the 2009 and the 2016 Aspen SCCM guidelines for nutrition in the adult critically ill patient. He was awarded faculty member for the European Society for Clinical Nutrition and Metabolism in 2011 and gave the 2016 Arvid Ritland named lectureship in Copenhagen, Denmark for that society. He's the recipient of the Aspen 2019 Distinguished Nutrition Support Physician Service Award, the 2022 Excellence in Clinical Practice Award, and the 2024 Bruce Bistrain Nutrition Mentorship Award. He is founding chairman of the Aspen Committee on Physician Engagement, which is very important. He is a diplomat and a past president of the National Board of Physician Nutrition Specialists. He was the co-chairman and lead author for the 2016 American College of Gastroenterology Guidelines on Nutrition Therapy of the Adult Hospitalized Patient. And he was awarded the honorary lifetime membership of the Academy of Nutrition and Dietetics. He's a fellow of Aspen, ACN, AGA, and the ASGE, and is an author of over 300 articles, 55 book chapters, and numerous medical educational videotapes, including a series of 14 videos on enteral access for the ASGE. His research interests and clinical expertise involves pretty much everything, but we'll name critical care nutrition and early enteral feeding, guidelines for nutrition therapy, and endoscopic techniques for enteral access and indirect calorimetry. We are absolutely honored to have you here with us today, and looking forward to hearing more about how nutrition has changed over the last 20 years. Thank you.
Wonderful. Thank you so much for that introduction. I'm going to turn it over to our panelists, and we will get started.
Ashley, Vivian, thank you for that kind introduction to both of us. And thank you for joining us this evening and taking time away from your families. I'm here with my buddy, Keith Miller. We've done panels before in the past. We're used to speaking together, but this is a new one for us, a virtual panel together. Our video production manager went home early. I'm sure nothing can go wrong. We have the IT skills of a squirrel, but we're going to do our best here to discuss a topic that's near to our heart. 15 years ago, we thought the dust had settled and we pretty much agreed on what we did, what the proper care, nutritional care of a critical ill patient consisted of. And then the panic trial came out from Europe. Preet Vandenberg was saying nothing in nutrition worked. It was followed by literally 15 years of chaos in my mind. And I believe that it's starting, the dust is starting to settle again, and we're having some pretty good consensus on the proper way to take care of these patients.
So yeah, we're honored to be here. Obviously, I need to add a couple pages to my bio just to keep up with Steve. I was a little embarrassed, quite frankly, and but no, he's been a friend and a colleague now for 15 years. We're going to go through some of that history because we went through a lot of it together. And Steve had a head start and has contributed to the field widely and impactfully. And in the last 15 years, I think some of the things that I learned coming through under his mentorship, a lot of that has changed. And I think that's what's exciting about having this discussion today. So I don't know, we're staring at a screen. Can anybody give me like verbal confirmation that you are in fact seeing the screen?
We can see the slides, yes.
Okay, perfect. Thank you. Sorry to do that. Like we said, our AD, yeah, we're really good at this. So first slide, disclosures. We're both serve on the Nestle Health or the Nestle Health Nutrition Fellowship. It's an educational fellowship where we take now what is predominantly faculty from across the country, and they spend 2 weeks here in Louisville with us, and then they spend a couple weeks out at Mayo Clinic. McClave's got several other disclosures that you see listed there. So we talked about it a little bit. We're going to kind of look at the last 15 years. We're going to talk about some historical approaches to clinical nutrition support. But I do think there has been a paradigm shift in this. And we're going to use a paper that we wrote together when I was doing the Nutrition Fellowship, because it serves as an interesting time capsule in what we were thinking was at that time. And then now we're going to talk about how nutrition support strategies have evolved and changed over that time period. So this is the paper. This is certainly not an endorsement of this paper. I don't know that you should read this paper.
It's a good paper. You did a good job.
Yeah, but really what it was a synopsis of a curriculum that we that Steve and Bob and Cindy went through in 2010. And we tried to merge all of what we knew about critical nutrition. It was coming off or during the SCCM Aspen Code guidelines that were coming out. So they had just critically reviewed all the available literature. And so we tried to synthesize that into a mnemonic. Obviously, the mnemonic's not all that important, but what is important is that this is what we were thinking at that time in 2010, which was subsequently published in 2011. This is Laszlo and Bob in Portland over here. They're at OHSU, and then Cindy, who's with the University of Louisville now. So what was the gist of this paper? Well, we tried to break it down into a mnemonic. We tried to design a mnemonic that went through important parts of the nutrition assessment and the initiation and implementation of a nutrition support plan in your ICU. The mnemonic, again, does not matter, but what you see is we looked at severity of illness, age, nutrition assessment, resuscitation, requirements, selection, access, efficacy, and tolerance. We thought these were important components that every clinician should have some insight into as they worked at the bedside to improve patient outcomes. You see pictures of Stan Dudrick in there, sort of one of the early innovators with TPN and other things. And so this was something we were looking at that point. Here, we are both here. This picture is embarrassing to put up here. We are representing our prime. So I do believe that I was in my prime probably in 2010, but Steve is very much in his prime right now. So he's going to represent our current approach, just to, again, give you some framework for understanding where we were at.
Steve, this is the year things were pretty steady in 2010. And then in 2011, the panic trial came out. And this was a review that Vandenberg, who was the main investigator on the panic trial, came out with a review in New England Journal. And it was just skewered our understanding. This is a table that summarized the article in which he looks at every aspect of feeding at the time. Early enteral feeding versus standard do nothing. Full enteral nutrition the first week. Use of prokinetics, supplemental PN, use of glutamine antioxidants. And look at this. Does it change outcome? Is it effective? No clear benefit. Inconclusive. No clear benefit. Basically, you read this article and it suggests that nothing works. And this just upset the apple cart and sent us in a direction that took at least another decade to get a hold of.
So this happened in the interval between when we're going to talk about what our sort of thoughts and feelings were in 2010 and current. And so we'll start with sort of the first question, which was severity of illness and the impact that it has on your nutrition support plan. And we acknowledge that that's an important piece of the puzzle in 2010, and how comorbidities and where the patient's at from a physiologic standpoint all contributed to how you would address nutrition support. McClave in 24 kind of reiterated that. But I think the important thing is in 2010, we kind of narrowed it down to a 2-question process to determine severity of illness and how nutrition support may impact that. The first question was, are they at nutrition risk? And that was sort of a novel concept at the time. And, you know, the question became, how do you define nutrition risk? Because it could really be a function of their pre-hospital or their pre-ICU admission status. What I'm talking about are comorbidities and the things the patient may come in with, but it also has to do with the severity of illness at the time they're admitted to the ICU. We sort of gravitated towards the NRS 2002. Since that time, many of you have read about the Nutrix score by Darren Hyland, and more recently the GLEM score. These are all attempts at trying to define malnutrition or nutrition risk in one way or another. The important piece of that question is, if you're at nutrition risk or you're not, does it change your approach in the ICU? At the time, we thought it probably did. The second question that you would ask yourself is, was the patient resuscitated or was the patient not resuscitated? There's significant concern about aggressive nutrition support in the under or unresuscitated patient, which we share today, but that was the second part of the equation, because then that led you to a very simple thing. Even a surgeon can follow this series of steps. So if the patient was at risk and they're not resuscitated, you held their feeds. If they're resuscitated, you started aggressive full feeding in 2010. If they weren't at risk, that was going to be a very small group in the ICU, because by definition, you ask the question, why were they in the ICU? Because any sort of severity illness would usually correlate with nutrition risk. But we would hold feeds in the not resuscitated patient. And in the resuscitated patient who was not at risk, we would do quote unquote standard care, or just give them time to make it to a tray. I think this is a significant change from that time. We're trying to peel the layers of the onion or add elements of nuance into what we're really seeing in our ICUs. And you will see this cartoon or this graphic multiple times if you're sort of scouring the critical care nutrition literature at current. This is put out by Van Zetten in a review article, and in addition with Lanier, they've all published versions of this. And what you're seeing is trying to parse out the individual layers of what your ICU patients look like. Are they in the acute resuscitated phase? Are they in the post-acute ICU phase? Are they in the rehabilitative phase? So over on the right side of your screen, what you're seeing is maybe a trauma surgeon's perspective on this, which is resuscitation, deconstruction, reconstruction, rehabilitation, or a burn surgeon might look at it this way. But really, you're trying to define where the patient is at within the phases of critical illness. And why does that become important? Because the central question I think we ask ourselves today is, where is the patient metabolically? If they're in the acute resuscitated phase and they're experiencing quote unquote futile energy cycling, they are entirely endogenous carbohydrate dependent for their provision, then they look like this on the left side of your screen, that so-called red light, where any nutrition support strategy may not be beneficial. As they progress through the phases of illness and improve, you may see some of this metabolic machinery start coming up and going. And then eventually during the rehabilitative phase, your hope is that they do not go down the path of chronic critical illness and sort of return to where the metabolic machinery is up and going. So that's a layered understanding that I think we're trying to push today that maybe we didn't have in 2010. So as you think about these issues, it impacts the things that we're going to go over next. And I promise Steve's going to talk more. So you don't have to listen to me much longer. Yeah. It won't be as exciting as you think it's going to be. But how early, how much, the route of delivery, and tolerance. I think there have been significant changes in those questions over the last 15 years. We'll start with how much, how early. In 2010, the caloric deficit argument was significant. And Steve and I would talk about, he would teach me all about how if you reach that 10,000 kilocalorie deficit, then your prognosis was significantly worse. That was true then, that is true now. But what that pushed us to do was start to aggressively feed the patient during that period of time. Since that time, we've had a couple of big trials. Todd Rice was one of the early ones through the ARDSNet group. He's a good friend, and this is a great trial to look at. With the Eden trial, where he looked at initial trophic versus full enteral feeding in patients with acute lung injury. So you can tell it's an older trial. Some of the terminology has changed since that time. And they saw equivalent outcomes. The next big trial that came out was the Arabi trial, large trial in critical care patients, and they looked at trophic feeding versus aggressive standard feeding, and again saw equivalent outcomes. So those two trials started to give us a clue that maybe we wanted to change our practice.
But this is a trial that really nailed it for most of us because it was so well done. Jean Rainier is an investigator from France, and he set up a trial in the sickest of sick patients. Mortality rate was between 42 and 45%, on the ventilator, in shock, on vasopressor agents, randomized to full feeds versus trophic feeds. And the trophic feeds, if you look at the calories, 6 calories per kilogram per day, the protein target 0.2 to 0.4 grams per kilogram per day, this is about 25% of what the full feeding group, the controls, were to receive in this trial. And the data just was stunning. The trophic feed group did better on most counts. 90-day mortality did not reach significance, but the time to discharge alive was shorter or better. The duration of mechanical ventilation, ICU length of stay, was shorter. But there are lots of other factors that showed that this might be the optimal way to feed. There was significantly less baggage as far as tolerance. So less vomiting, less diarrhea, less abnormal liver enzymes. Glucose control, evidence of refeeding hypophosphatemia and ischemia was less in the trophic group. I think there was about 1/4 of cases of ischemia in the trophic group compared to the full feed controls. No difference in the other outcomes. In this, there's a couple concepts now that we need to ask ourselves. And this is a concept that Jay Patel put in a really put together, and Jay and I were arguing about, how do we benefit patients across the spectrum from mild to severe disease? Do we cause more harm or less harm as we feed? And I said, Jay, it's a bell-shaped curve. And that's shown on this slide. That as you go from mild to severe critical illness, there's a point at which we get our maximum benefit from nutritional therapy. They're sick enough that nutrition therapy is going to improve outcome. If you're on the far side of that to the right, that's the Nutrien trial we just showed. And if you push hard in that group, the chance for a benefit falls off. You're less likely to change outcome. On the other side of the curve, at the left side of the curve, and these are trials, the Apanic trial, the Python trial, those patients weren't that sick. It doesn't matter how much we feed them because really the chance of improving outcome it goes down. This was shown beautifully in that effort trial, the trial on that last slide that was at that sweet spot, the peak. This was hospitalized patients with malnutrition randomized to a protocol of PO, then enteral, then TPN if they weren't progressing fast enough versus hospital food. There was a difference in 30-day mortality, but they saw it at the peak or slightly to the left of that peak in the low inflammatory and moderately inflammatory group. These groups were based on C-reactive protein levels. But the group that was the sickest, the high inflammation group, there was no difference in mortality between the protocolized feeding regimen and the hospital food. It thought this was a true fact, and then Leanne Chappell from Australia provided a study that might explain why we would see this fall off in the chance to benefit from our nutrition therapy in the sickest folks. She took 15 patients in the ICU on mechanical ventilation and 10 controls. And then she radio-labeled phenylalanine and infused it into the duodenum, and she also gave it intravenously into the circulation. she was able to show that both groups absorbed the amino acid from the GI tract. The levels in the circulation were the same, but when it came time to incorporate the amino acid into protein synthesis, the ICU group was 60% lower. This was anabolic resistance. They couldn't utilize what we were giving. And that may explain why we fall off. Our chance to benefit from our feeding falls off if they're really severely ill. Jay said, no, Steve, you're wrong like usual. It's a U-shaped curve. This curve is showing that concept. On the horizontal axis, we're going from 0 to 100% of requirements being delivered. On the vertical axis is the chance of causing harm. So we think if you're not feeding somebody and bowel integrity it diminishes and you get a pathogenic pathobiome, that harm goes up. As we start to feed by the enteral route and bathe the mucosa and stabilize mucosal defense, then the harm goes down and the curve flattens out. The Eden Omega trial provided 20% of requirements for 6 days. The Arabi Permit trial provided about 50% of requirements, and there was no difference in these studies between the underfeeding and the full feeding group, suggesting there's a neutral zone in which the curve flattens out. And then you get to the Nutrija 2 and Nutrija 3 in these severely ill patients, and when they tried to push to, or when they did push to 100% of goal feeds, harm went up, outcomes were worse. And yeah, you got to ask yourself, feeding, we think that was good for people. How can we possibly cause harm with feeding? And there are at least 7 reasons. The first is probably the hardest to understand, and that is when the patient's critically ill, the liver is pouring out glucose. That's hepatic gluconeogenesis. Anything we add to that can inadvertently result in overfeeding, because that's what the tissue sees. And sure enough, in the Nutrija 3 trial, the full feeding group had more trouble with hyperglycemia, required higher doses of insulin to control those blood sugars. Second thing that's at risk is bowel ischemia. And sure enough, both in the Nutrija 2, which was full feeding enteral versus full feeding PPN, and then Nutrija 3, full enteral versus trophic enteral, the group that got full enteral had a 4 times higher rate of bowel ischemia. Risk of refeeding syndrome. The harder you push in somebody at risk for refeeding syndrome, the more trouble you're going to have with electrolytes and actually precipitating refeeding syndrome. Sure enough, Nutrija 3, there was more cases of hypophosphatemia with initiation of feeding in the full enteral group. Fourth thing, as you push hard, you're dealing in a situation where you have failing mitochondria. They're dysfunctional. They're starting to fall apart and fragment, spill their guts into the circulation, which promotes further inflammation. In a situation like this, by pushing full feeds, we are increasing demand on these mitochondria. They're struggling to deliver the ATP. So what happens? They hibernate even more. That clinically at the bedside looks like organ failure. The kidneys, instead of perfusing 100% of the serum plasma, it'll drop down to maybe 60% filtration. And the creatinine will sneak up a little bit on biopsy, pretty normal biopsies. There's no structural abnormalities, but this is the mitochondria hibernating, and lactate levels go up because of chlorine cycling. Sure enough, in the Nutrija 3 trial, the group that got trophic feeding normalized their lactate levels faster, and their return of organ failure was faster with the underfeeding. Autophagy is this mysterious process that's supposed to clean up bad muscle, which we think would help reduce post-ICU muscle weakness and recovery. And the more you feed, the more you inhibit that process. And then with full feeding, you have these excessive fluids that's going to impinge on the respiratory system. And sure enough, in Nutrija 3, there was delayed weaning from mechanical ventilation in the group that got full feed and more fluids. And then finally, when you push enteral feeding that hard, you got all the unwanted baggage from intolerance. The nausea, vomiting, abdominal distension, a reduction in their attempt to get to the goal they wanted, higher use of prokinetics to overcome that baggage.
So I think, that's changed the way that we approach the critically ill patient from a how early standpoint and a how much.
Yeah.
And I think when you look at their energy requirements in 2010, we've tried to, we considered calorimetry and maybe where its place is, and we're going to talk a little bit more about that later. But really, when it came down to it, it looked like weight-based equations were probably the way to go from both a caloric and a protein provision perspective. Mm-hmm. And that's where we were. Now, today, what you're seeing, one size may not fit all, right? And so popular in the literature now is the concept of personalized nutrition therapy. And in many ways, what they're talking about when they use the terminology personalized nutrition, they're talking about maybe cart-directed nutrition support in your ICUs. You're seeing it in, what do we got? We got here, we got severe diseases during hospitalization, disrupting cancer, chronic degenerative diseases. So you're starting to see this terminology pop up. And really what they're talking about is trying to target what you get from a cart to show you what the next step in how much you want to deliver at the bedside.
But the idea is that, our patients are like snowflakes and everyone's different and we got to know exactly what they're doing. In nutrition, it gets shoved down our throats via indirect calorimetry. And these are three investigators I love from Europe, Pierre Singer, Elizabeth DeWall, Claude Bouchard, and they developed this phenomenal new indirect calorimeter that's cheaper and more portable and gorgeous. But with that was the idea of personalized nutrition. To provide optimum nutrition, we had to measure their requirements and then meet those requirements exactly to optimize care. In our American guidelines, we said weight-based equations are adequate. We don't need to use the cart every day. We only need to use the cart when the weight-based equations fall down because of anasarca or gross super obesity or amputation, something like that. Now, the support of their argument is the caloric deficit. And this is Keith alluded to this earlier. The earliest was from 1982 when Robert Bartlett in Michigan said, patient comes in, is expending calories every day. It takes us 5 days to get the feeding started. Maybe it's 2,000 calories a day times 5 days. That's a 10,000 calorie deficit. When they exceeded that, mortality went up threefold. Jim Malt, who was in Bartlett's lab 20 years later, repeated that kind of study and showed again the point at which you got above a 10,000 calorie deficit, duration, mechanical ventilation, ICU length of stay went up. And DeVere, who was in Pierre Singer's group in Israel, same thing. But this time he said, man, if you get above a 4,000 calorie deficit, all the complications go up. So this basically said we have to be as aggressive as possible. This would support measuring their needs and meeting those needs within 24 to 48 hours. Well, there's data now that suggests that we don't need an exact number. The EAT ICU trial did just that. They randomized ICU patients to get measured on the cart every day and a urine urea nitrogen to calculate protein requirements. And when they got those numbers, they then added supplemental TPN to the tube feeding to deliver that number. Controls, they just used weight-based and they didn't add the supplemental parenteral nutrition until after the first week. No difference in outcome between the exact measured group and the sloppy weight-based group. No difference in outcome. The second study says if you have a number, either by the cart or by your weight-based equation, you have to deliver that amount. And the target trial from Australia would say no. This was a group that actually was using an interesting strategy. They were comparing a concentrated formula, 1.5 calories per cc, to a standard 1.0 calories per cc formula, but in an effort to deliver more calories. At the end of the study, the treatment group in the concentrated formula got 30 calories per kilogram per day. Controls on the standard formula got 21, 22 calories per kilogram per day. No difference in outcome. And to us, that says if you're in the ballpark, you're 78% of whatever number you got, either by the cart or by the equations, you're probably okay. Outcome is going to be no difference if you push the full feed. But let's say for a minute they were right and we're wrong. Then there should be randomized, and there are. There's 7 randomized controlled trials. I shared one with you, the EICU, but there's 6 others in which they randomized the full feeding, where they either measured it or used a number and added supplemental TPN to the tubing to meet that number versus controls where they just went with the enteral feeding as much as they could and held the supplemental PN for at least a week. And not to go through the details, but basically only one study by Gao, and that's a study from China, showed that the a weight-based equation and meeting that number reduced nosocomial infection. All the other trials are negative. The Heidinger study said other infections were less with the cart-directed therapy, but it was odd nose, skin infections only after 9 days. That's a negative study. The rest of the studies showed no difference. So it sounds like this would support the idea that we don't have to have an exact number. We don't have to meet that number. And if we're just in the ballpark, we should be okay. Now, having said that, somebody's going to pull you aside and say, you know, I think I read that using the cart reduces mortality. And you got to be ready for that because it's a little bit of a mixed, sloppy message. The plausibility outright is a little silly. The idea that we have 2 patients in the ICU and we just turn the cart on, let them breathe on it for 10 minutes and get a number that's going to save them and reduce their mortality. So right out of the batch, right out of the hatch, out of the gate, I think it's a silly concept. But here's the data. There was a study in China, 60 ICU patients. All we have in English is the abstract. You can't read the rest of the article unless you can read Mandarin. And what they showed was that there were 7 deaths out of 30 in the group where they used an equation to direct nutrition care, 1 death out of 30 in the group that used the cart. And it was highly significant. Then there was a second study by Gonzalez that went the other way. There were 5 deaths versus 3 deaths. 5 deaths in the cart directed, it was worse than in the equation directed. So then 3 meta-analyses took a combination of other trials and whether they included or excluded these trials, they got different results. The first one, published first in 2019 by Tatuka, showed that use of indirect calorimetry actually made things worse. Duration of mechanical ventilation was longer, mortality was no different. And they excluded the Yang study from China. The second meta-analysis included the Yang study, and that tipped it in favor of indirect calorimetry, and they showed that use of the cart reduced mortality. And then the third one by Pierre Singer's group, Petrov, he excluded Yang, but he also excluded Gonzalez for reasons that are not clear. And they showed that metabolic cart reduced mortality. So I think this is an incredibly shaky argument. We can't believe that simply turning on the machine would pull people out of the woods and save their lives. But the data is as it stands.
Yeah, so the role of indirect calorimetry, I think we talked about a little bit. And so we talked about how much, we talked about how early, how do you determine what's needed. And so the next biggest change that I think is worth talking about, in 2010, there was a heavy emphasis on the superiority of EN over PN. Multiple trials had sort of demonstrated that EN beat PN every time. We, in our sort of paper, our manuscript, sort of reinforced the idea that the supported limited indications for the use of parenteral nutrition. So that's where we stood there. In 2001 is when we wrote TPN was dead, at least in the ICU, for ongoing nutrition support. Obviously, there's multiple indications. That's where we were at in 2010. So where are we at now?
Yeah, I think we might have pushed too hard on this concept because 2 trials have come out since then. The Calories trial from England was enteral versus parenteral for 5 days in a mixed ICU population across community hospitals in England. And they showed there was no difference in outcome between the 2 routes of therapy. The Nutria 2 trial by Jean Renner, EN versus PN over 5 to 6 days in MICU patients in septic shock, on vasopressors, on the ventilator. No difference in outcome between the 2 groups. But in the Nutria 2 trial, the PN group could cross over to enteral within 3 days. And so we're talking about 2 studies where there's fairly short-term nutritional support. What's the impact of these trials? How do we interpret this? They're very good trials, very important. It says that under controlled conditions in high-risk patients short-term PN can approach the outcome of enteral tube feeding. Every guideline except one still says that enteral feeding is still preferred over parenteral. The physiologic response to enteral is totally different than the physiologic response to TPN, but as clinicians, it should lower our threshold to go into TPN when the tube feeding isn't getting the job done.
Yeah, and I think, part of the equation as you put all this together is to say that if you wouldn't use EN, you're probably not going to use PN. Is that safe to say?
Yeah, I think so. If you're in the resuscitation phase, if
Right.
it's hemorrhagic shock and trauma, you got to get all those hatches batted down before you can consider entering the acute phase and starting to ramp up your nutrition support.
And I think going back to that question of where are we at metabolically, I think PN, we have a lower threshold for using it if we feel like metabolically they can metabolize those macronutrients then. And for one reason or another, EN's not tolerated. Is that when we should think about shifting to parenteral nutrition?
Yeah. One final caveat on that particular subject: if they are severely ill and it's clear that EN is not feasible, we would probably start fairly soon, within 24 to 48 hours with the TPN. If you've got tube feeding going, we really still say, and almost every guideline agrees with this, you would hold supplemental TPN added to the tube feeding until after the first week.
So one of the last issues we kind of talked about was tolerance in the ICU, which can be a significant problem. Certainly in 2010, I do think when we were aggressively using full feeding strategies, we had a few more tolerance issues than maybe we do today. But by 2010, we sort of had recognized that gastric residual volume for leukorrhea. One trial was out. We were kind of multiple trials since that time have sort of demonstrated the same thing, that maybe residual volumes weren't the best way to follow tolerance. And so I think we were on to that in 2010 already. But so whenever you remove something from the equation, okay, so you can't use these for tolerance, what are you left with? And so what do we replace gastric residual volumes with today?
This is a very good investigator from Estonia, one of those Russian, part of the Russian bloc that's now independent, free country. She's been working on this with a group of anesthesiologists called the European Working Group on Abdominal Problems. And it's basically tolerance. And what they've shown over a decade of work, a very good work, is that the association between evidence of GI dysfunction and disease severity and subsequent reduction in survival. And this 1 through 4 is graded worsening of intolerance or GI intolerance and decreasing survival. So that has been shown time and again. The problem comes in how they define intolerance. And this is a table of a decade worth of investigation in which they started with the signs of dysfunction, which would be abdominal distension, nausea, vomiting, are they failing to pass stool and gas, are you having trouble with feeding intolerance and not getting to the goal that you set. That's what we should focus on. But over a decade, they'd start to add other things like intra-abdominal hypertension, bleeding, diarrhea, as if this were a spectrum. And you start with abdominal distension and hyperactive bowel sounds, and if you don't nip it in the bud, you're going to end up with bleeding and diarrhea. That's not the right approach, I don't think. I think it's proper to use the GI signs. Anika Blazer, the one thing I disagree with her, she won't let go of residual volumes. And if you read her data, residual volumes are all through it, as you can see on this table. And every time you get a group of experts in critical care, they say, please stop using the residual volume. Diarrhea and GI bleeding have their own differential. Diarrhea, for example, 50% of the time it's medication. The other 20% it's C. diff. It can be related to the feeding, but the other things have to be eliminated. GI bleeding would be stress gastritis, in which we push the feeding, not back off. If they're cirrhotic and it's a variceal bleed, different story. The last thing they're doing now is the Estonia group is separating from upper to lower signs. And this is misleading because really the GI tract kind of operates in thirds. You got gastric, small bowel, and colonic motility. and the sequence in which they stop contracting and the sequence in which they return is pretty predictable. And saying upper versus lower doesn't help us with that understanding.
So yeah, it sounds like clinical exam is still going to be a huge
Huge
part of
factor,
determining
yeah.
tolerance.
Yeah.
And so, you know, when we talk about what's the current focus of nutrition therapy at the bedside today, what do you see as important? I feel like I'm interviewing now. This is nice. It's like around 60 minutes.
This is killing him because obviously it's clear that we need a gastroenterologist.
No
And I
doubt
think
about
you
it.
would agree that that's just who's killing your soul. But the discussion here, this discussion affords an opportunity in which we can use the gut as a conduit to modify these immune responses as well as the microbiome and gut defenses. If we are unable to feed for any variety of reasons, it's like a rheostat on the wall. We crank it to the right, and the gut can actually accelerate the inflammatory response, accelerate worsening of virulence, pathobiome, growth of the pathobiome, organ failure, gut sepsis, in which the patient looks clinically septic, but there's no pocket of pus anywhere. Some of these bacteria, when they become virulent, produce collagenase and actually can lead to dehiscence of a gut anastomosis that the surgeon just did earlier in the week, antibiotic resistance, and increased mortality. On the other hand, we can utilize the gut for feeding, crank the knob to the left, in which we modulate these responses, support commensalism, refaunate the microbiota, increasing tolerance, faster resolution of the surge response. And we see this predominantly in pancreatitis. We're now seeing it in COVID-19. If you've ever done a fecal transplantation in somebody in the ICU with C. diff colitis, you do the FMT, restore commensal bacteria, or promote commensal bacteria, and they turn around overnight the surge response. Does enteral feeding change the outcome? These are our forest plots from the 2016 guidelines looking at enteral feeding versus no enteral feeding. And when they didn't do early enteral feeding, they either delayed it to day 4 or later, or they just said they're on their way. They're on their way back to a tray on their own. When you provide early enteral feeding, infection was reduced almost in half, and that was statistically significant. And mortality was reduced again almost by half, looking down to about 9%. The problem with this, the guidelines were written in 2016 on data up to 2013. We have not had a lot of studies since then, so it's somewhat old study. A lot of these studies were done before tight glucose control, but I don't think we have any data that contradicts this concept. And we have a little bit of data now from COVID-19 that actually supports it.
Yeah, so going back to this slide, I would say, so trying to put these two things together and reconcile the things we've talked about in the last few minutes. I think, where's the patient metabolically, and what are you trying to accomplish with early enteral nutrition? Maybe the goal has changed a little bit. You're not trying to meet caloric needs. You're not really even trying to provide energy or substrate for energy at this point. It's really about trying to manage the local gut ecosystem and make it as happy as possible. So it sounds like a complete strategic change in what we're doing.
Yeah, we used to told that we have to get all those calories and protein in to support the immune system, but that strategy doesn't work. What works is bathing the mucosa and using the gut as a modulator. And we're still starting early, hopefully within 24 or 36 hours. What's different is the big crank up we did before. We're now leveling off at a perfect dose.
And so here you're going to talk about the
it's just a quick thing, couple references for you. But it turns out what we learned in the COVID pandemic is whether you could contain, everybody's exposed to COVID-19, the COVID virus, through aerosolization into the lungs. Whether you could contain it in the lungs depended on the health of the gut. And if the gut was healthy, you didn't get penetration beyond the gut, beyond the lungs, to other organs that had H2 receptors. So the healthy gut was a determinant by mounting a robust but appropriate immune response, the virus could be contained in the lungs and prevent widespread dissemination. And then finally, we overplayed the risk of fiber in the 2009. We softened a little bit in the 2016 guidelines, but not enough. We now realize that fiber, soluble fiber, converting it to short chain fatty acids, and specifically butyrate, is very important. The butyrate is magic, both for local and systemic anti-inflammatory effects. Not only does butyrate support gut barrier defense, it stabilizes hypoxia-inducible factor, which in itself stabilizes barrier function at the gut level. Butyrate affects polarization of macrophages, moving from an M1 pro-inflammatory to a resolution anti-inflammatory macrophage of the M2 phenotype. It stimulates G protein receptors and inhibits HDAC, which are processes that hitting those receptors and inhibiting HDAC reduces inflammation systemically across the whole host, the whole body.
So, we took a little silly trip down memory lane when we talk about the time capsule from 2010 and where we're at where we're at today. And we talked about a lot of different issues, and we wanted to leave a little time for questions. So, as far as the take-home messages, what would you say we take from this?
Yeah, I think what makes nutrition personalized and unique is not some weird snowflake concept that involves the cart. What's personalized is your protein evaluation, the timing, initiation of your feeds, and then monitoring and making adjustments for individual intolerances. Measuring on the cart is not needed, and I'm a cart head. I love the cart, and it helps us understand what's going on with the body. It's not required day in and day out with individual patient care. Future research may need to focus more on mechanistic studies. These large randomized trials looking at do-week change mortality, those are often negative, like over 90% of the time. Focusing on mechanisms and whether the nutritional therapy is changing those mechanisms like inflammation may be more appropriate. The timing and early initiation of tube feeding is important, but the amount of calories and protein is less important. And I see patients should receive less with a slow ramp up in the infusion rate to a trophic level during those acute phases. The focus of enteral feeding should be on maintaining gut defense and supporting the commensal microbiome.
So I think that's good. And I think at this point, if I can figure out how to work this, we'll try to take any questions that y'all might have.
Thank you so much for that informative presentation. Let's see. If you have questions, you feel free to put it in the chat or the question. There's a question tab. Let's see. I do see one question in here, and one of the questions is about. When do you feed the gut for mechanical ventilation patients who are on vasoactive drips? Please speak to all vasoactive drips.
Yeah, I think, the fundamental question goes back to, you can't take out of the equation how you feel as the clinician at the bedside, where the patient's at within those phases of illness. So I would never say, I would never tell you, I would never feed on epinephrine. I would never feed on any particular pressor that you want to talk about, okay? It's within the clinical context. If they're on a stable dose of pressors and you feel like they're outside the acute resuscitated phase, then I might start some trophic feeds relatively early. Certainly there are VIS scores, there's information out there that you can find where people have tried to quantify how much pressure is too much, but unfortunately nothing beats your sort of clinical judgment at the bedside to try to determine where they're at. Certainly, I think asking yourself the question, where is the patient metabolically, is an important component. We have some patients that are on pressors for very prolonged period of time, and I'm not convinced that they're metabolically incapable of dealing with substrate. And so at some point, clinical decision or clinical judgment wins out, and you move forward when you feel like it's safe.
Yeah, I'll add to that because I've asked I'm a gastroenterologist, so this stuff gets outside my area of expertise. But the argument that I hear most importantly from the CIMA-RAVI is it's the response to the vasopressors that's most important. And if they're stable for 24 to 36 hours and mean arterial pressures are above 65, it's safe to start feeding and watching them closely. Paul Wishmeyer and Jay Patel have tried to tease out the agents, and the one they seem to focus on is norepinephrine, and they have a dose cutoff where above that they're nervous, and I think it was 0.5 milligrams per minute. Is that right? I think got the units right. Above that, they're nervous, or is it 0.3? Or below that, they feel safer. But I think the general rule is stable doses. You're coming down from 3 to 2 to 1 vasopressors over 36 hours, and you got enough new arterial pressure. You're okay.
Yeah, and I don't ever use a dose break point. That's not the way we practice clinically here, and maybe we're doing it wrong, and that's certainly possible. But there's not a number. It really depends on trends, as so many things in the ICU go. So you've got a critically ill patient that you feel like is getting better, then I may start some early nutrition support on a dose that otherwise, if they come in the door and they were doing great and now they're on that dose, I certainly wouldn't even consider it. So I think trying to put your patient in the bucket of which phase of critical illness they're in is the most important step.
If you are aggressive and feeding on vasopressor agents, I think you have to watch them closely. And any change in those tolerance signs that we talked about, if they have new abdominal extension, if they stop passing stool and gas, I think you have to stop, because you may have gotten into some problem.
And to clarify, we're not talking about full aggressive feeding strategies right now.
Very low dose.
We're talking about low dose trophic feeding during that period of time. And we certainly aren't advocating to start every one of your patients on pressors on that. No, it's within the clinical context.
And the last thing that'll drive you nuts, if you pull the literature on ischemic bowel and tube feeding, it's not always during the period of hypoxemia or hypotension. Sometimes they can be going great for 5 or 6 days, and all of a sudden there's something that you have to change clinically, and you've got ischemic bowel. It's not as clean and neat as we would like to see.
Great. Thank you so much for that in-depth answer to the question, because that comes up all the time in the ICU. And there's really, a lot of it is based on provider preference and the clinical condition and their response. So we appreciate that response. There's another question in the chat. Is butyrate an additive, or do most enteral feeds contain it?
Take that one. Yeah, butyrate is a product. It's a short chain fatty acid with propionate and acetate, a breakdown product of soluble fiber. And so one of the things where we before said don't use fiber, it's too risky, we now believe, and see if you agree with this, that if it's safe, if you feel it's safe enough to start enteral feeding, then you should start a fiber-containing formula, a particularly soluble fiber, but a mixed fiber formula is probably appropriate.
Yeah. No,
Now, interestingly, there is a drug called tributrin, and it's 3 butyrates hooked together, and they've used it a lot in animal experiments. It's broken down to butyrate. It does have the trophic effects we're talking about. I don't know how well it gets down to the cecum, the colon, where a lot of this action is, distal small bowel, but we don't have as much information with that.
Great.
You had an interesting argument. I'll throw it out. That table I showed from Greek Vandenberg saying nothing worked. At one point early in the week, Keith turned to me and said, "Well, you think she was right in retrospect?" And at the time, I was horrified. She was just thrashing nutrition. I didn't sleep at night. I was crabby at home. But she had a lot of points there. We were being too aggressive, and it was hard to point to the benefit of that kind of aggressive feeds. So in that respect, I think she needed to wave the flag and say, this is too much. We got to rethink here. Where's the benefit with what we're doing? And the only criticism I have of the articles was almost like an nihilist that sounded like there was nothing we were doing was going to help. But she did a valuable service for us to have to step back and say, let's rethink what we're doing.
And it takes a big person to say that. So I'm really proud of We're really proud of Steve for admitting that we were wrong. And then also, I'd like to just say, Kristen, a pharmacist here at University of Louisville, helped start this connection. So I'd like to thank her. I don't know if she's on. She probably didn't show up, but I'd like to thank her for being on here. So Kristen, if you're out there, hello.
Excellent. Excellent. Thank you. I have one more question. I know we're wrapping up. So there's a question again about vasoactive drugs. What vasoactive drugs would cause gastric ischemia, and what are the best guidelines or the latest research? There's also a shout out that y'all are the best. So
which vasoactive drugs? So I think, obviously, your choice of vasoactive drug is largely going to be dependent on the etiology of your shock that you're trying to address more than anything else. Certainly, norepinephrine is the most common in our ICUs because I'm a trauma surgeon, right? And so I think, you have to think about it in all of them. I think any pressor that you're using that's in the back of your head, that's a soft stop spot, but as far as data on which are worse, I think it's more of a dose-related issue than anything. But I can't answer that, if I had to pick one pressor, I think really you're not going to choose a pressor based on risk of bowel ischemia typically. You're going to choose a pressor based on why is your patient in the ICU and why are they in shock.
And if you've started feeds and now have to initiate vasopressor therapy, or you're adding the second, third agent to your first agent, you've just got to stop the feeding. I think it's not safe to continue feeding in that sort of setting.
Great. Well, thank you so much for your time. I think those are the questions. I don't see any more questions in there. So with that being said, I'm going to turn it back to myself. And again, thank you all so much. I see that the sun's set over there, so it's dark. So appreciate it so much. And if there are more questions, then we will continue to chat and send it forward your way. Thank you all so much for attending. Appreciate it.
Well, thank you.